Welcome to Good Sex at NYU, a podcast about sex, relationships, health, and mental health in a sex-positive space. So if you're looking for sometimes serious, sometimes funny, and always sex-positive discussions, then you're in the right place. I'm Danielle Elliman, Associate Director of Sexual and Relationship Respect Services at Counseling and Wellness Services. I use she, her pronouns.
And I am April Fellers, a nurse and sexual health educator at the Student Health Center. I also use she, her pronouns. We are two white, cisgender, heterosexual, female-identifying clinicians, one with a medical background and the other with mental health experience, who seek to create a space that is inclusive of all identities, backgrounds, and perspectives. Today on Good Sex at NYU, we are continuing our conversation with our colleagues Dr. Virginia Robertson and Dr. Sandra Curet, who are medical providers in the GYN Health Department at the NYU Student Health Center. In the last episode, we spoke about various services available in the GYN Health Department, as well as pap smears and HPV, or human papillomavirus. While these episodes are independent of one another, I think listeners will find the information from our last conversation really helpful. So if you haven't had a chance to listen to that episode yet, I highly recommend it. Today's topic is dyspareunia, which at its most basic level means genital pain during or after sex. And that definition is extremely broad. And just thinking about my own experiences and experiences of other friends, I feel like there are sometimes that sex can be painful, you know, if it's your first time or there's no lube. So I'm curious what your clinical experience has been with dyspareunia, if you can kind of describe what you see in a clinical setting.
Sure, I'm happy to do so. And I think it's a really important topic because we see it, you know, we as GYN clinicians, you know, hear about this pretty often from folks. And you're right, sometimes it's just because it's the sexual debut and it's the first time and everything's kind of getting used to everything. But what we really hope is that people can have, you know, consensual, essentially, you know, generally pain-free sex, pleasurable, you know, really a meaningful part of their life. And so for those that are experiencing discomfort or pain during sex and they don't, and it's not acceptable, you know, for some people that might be okay, but for those where it's not acceptable, we certainly hope that they have the ability to say, one, you know, to their partner in the moment, let's just hold on here. And two, maybe begin to do some sort of thinking about, well, why is it painful? Is it something about lube? Is it, you know, was this really what I wanted right now? Is there some other kind of intimacy that I prefer right now? Mm-hmm. Do we just need some more lube? Do we need a different position? And sometimes some of those things are discoverable and can be solved and you know, with good communication. Things like your series actually probably goes a long way to help people understand about the sexual response and their own bodies, their decisions about sex, mm-hmm. Cultural norms about mm-hmm. sex. And that helps, you know, also, you know, make this, you know, even if it happens as sort of hopefully a transient kind of thing. But if there is, you know, kind of persistent pain with sex, that's where we certainly hope that folks will come in and let us help them, you know, and really talk about what the situation is and begin to do some of the assessment of the dyspareunia.
Mm-hmm. And is dyspareunia a clinical diagnosis? And what are the criteria for someone who is generally diagnosed with this condition?
We think of it as really a descriptive term, right? Dyspareunia, pain with sex, basically. But when we hear that it's repetitive or recurrent, persistent, not going away, and it's really interfering with the enjoyment of sex or just causing distress, that's when we really begin to think of it as something that should be further diagnosed and really kind of delve into, well, what's the underlying problem or the contributing problems, because sometimes it's more than one thing, potentially. Mm-hmm.
Yeah. So what does that clinical process look like?
So if we talk about pain during sex, but actually it's genital pain, right? So it could be mm-hmm. from any part of the genitalia. So that's part of like a bigger scope of a diagnosis mm-hmm. itself. And that will be in male or females, again, or trans, you know, any a pain during sexual activity. So the focus will be female genital pain during a sexual activity. And the process will be first to the interview. So we'll have to get the history to see how long this is going on. Is this a first time? Did you enjoy having sex before now? And now this pain is happening. And where is the pain associated with what? And there are conditions like, we mentioned briefly in terms of, was it in your menstrual cycle? Were you in a position, lubrication, right? Or there is something else underlying that is causing this discomfort or pain. So for the various areas, it could be dyspareunia, which is strictly penetrative pain. So when there is penetration, there is pain during penetration. It could be vulvodynia, which is pain in the vulva area or the introital area, the entrance to the vagina. Or is it because you have some vaginismus that now is causing deep pelvic pain in addition to pain during intercourse? And then you don't have to have, as I mentioned before, intercourse to have the pain. So is it something that is during masturbation? Is it something that is during foreplay, during playtime? What causes in this arousal process that this is constricting and this is painful? That's kind of like the description, right?
You just mentioned a couple terms, vulvodynia and vaginismus. What are the kind of the similarities and differences? And then I'm also curious if there are terms for somebody with a penis.
So is dyspareunia for penis because it's, pain, dyspareunia in female or male. That's the same. A vaginismus, well, that doesn't apply, or vulvodynia because they don't have a vulva or they don't have a vagina if it's a male gender sex, from the beginning. But if it's a trans and they have not done reconstructive surgery, and they do still have vulva or vagina in addition to other, right, then it could be painful, okay? And that could be due to medications and scar as well. So going into the vaginismus, for example, so that is involuntary contractions in the vagina. So your pelvic floor muscles, so the vagina has muscles around it and connective tissue that is holding everything in place, and then that contracts. It's almost like, your muscles here are contracting when you do it like a workout. So basically that's exactly, the vagina is working out. It's contracting, it's squeezing the vagina in there. I mean, if you have heard the term of Kegel exercises, familiar with that, right? Or when you try to hold the urine, you don't want to pee, or you don't want, to hold your bowel movement, like you're like constructing all that, pelvic floor. So that happens involuntarily. So that's vaginismus, something that you don't control, you don't know what is going on, and there could be conditions that is provoking that. So that's part of our investigation in your evaluation.
Yeah, and vaginismus, that concept that it's involuntary often is something that is really good to share with folks because it's subconscious. It's not, and so they don't have to feel guilty about it. It is a reaction that happens and can be unlearned over time, probably, that the muscles can learn to relax differently. Vulvodynia is a little bit more around the external structures of the vulva and, can be many things, but it has to do with kind of the skin and the nerve units being perhaps a little hypersensitive, abnormally sensitive, or just indiscriminately sensitive. It can be a large number of different things, but as you can imagine, even with just simple touch, sex play or masturbation, that can trigger, kind of that kind of pain. Or odd sensation in someone with vulvodynia. And then because it, if it's going to be penetrative sex with a toy or with a penis or fingers, it could just, it's the entry point. So it can be difficult. So it can be any of the structures of the outside. And there's a lot more discernment that has to happen about like where. A lot of times we encourage folks to show us on a picture that we might have on the wall of where they notice the pain, or we use a mirror so that they can go ahead and point it out to us so that we can then, look very closely. Sometimes it's something quite local. There can be infections that are local on the skin that if we treat the infection, hopefully the nerve overreaction will subside. Sometimes there are scar tissues that you alluded to that, need to be assessed, or other primary skin conditions. that can cause this. I think probably all of us here realize that once there's some pain having to do with sex, you become a little anxious about it, and then that becomes this vicious cycle, right? So because you suspect that pain is going to hurt more, so you kind of maybe do some more avoidant,
pain memory,
and then it all just kind of heightens it. So those are sort of some of the common reasons for dyspareunia. Other infections more deep in can also cause dyspareunia. So somebody who's got gonorrhea, chlamydia, maybe they have pelvic inflammatory disease, that usually is more associated with pain with like deep thrusting. Or endometriosis also can be sometimes associated with dyspareunia because of the process of endometriosis causing some scar tissue deep within the organ, the structures in the pelvis. So these are sort of some other areas that we end up sort of thinking through as we hear about the history, and have the person, show us what they're experiencing.
I just realized for the first time as a pregnant person that the cervix is a little more sensitive when you are pregnant. And so that also that was surprising to me. And I was like, oh, that's a different sensation and a little bit painful in a way that I hadn't expected.
And that is because it's coming down.
Yes, because it's like
it's a lot of pressure. So now you have what we call organ prolapse, even though it's not really prolapsing that you can imagine it's coming outside, but it is in a different position.
Yeah.
In a different level. So now it's reaching out easier and then it hurts more. But positional also can be helpful. And that's one of the things that, obviously, we examine and then we counsel about.
You asked about folks who have a penis, and so they can also have pain with sex. Usually with erection or ejaculation. It's sort of it needs to be delved into itself uniquely. But again, scar tissue, right? Could with the expansion of the penile tissue, that might be the reason for it. There are some underlying kind of conditions that are hard to define as to why that occurs, but those kinds of things can happen too. So it takes some delving into.
Yeah. And what are some of the causes? Like, is there, I'm thinking about from my perspective, sometimes I'll see someone who's experiencing pain in that, like, it could potentially be mental health as well. Like they've experienced some kind of trauma. Like, are you like sort of looking into that as well as you're like doing your assessment on, again, you want to maybe rule out some of these other things, but then also sort of taking into consideration what kind of trauma they might have in their past.
Oh, absolutely. Yeah. Oh, that sort of, I think that's just part of our basic history taking to find out about that because, it will inform, how we approach everything and it can be an important discovery to kind of think about, well, what are going to be the best therapeutic approaches? Because, as I sort of said, you've got that pain, anxiety syndrome, and, certainly something where there's trauma that, caused pain, that in and of itself, has its own kind of approach of treatment. And really, doing both at the same time, even if there are some physical things that need to be done to help alleviate the vaginismus or the vulvodynia or whatever, that working on both of them together is critical.
Yeah, and I don't know if you read recently, the newspaper was this article in the New York Times about the rape or sexual assault victims and a description of term of freezing.
Yeah.
So this is something that I just bring up because sometimes, when you ask them about pain and their history, they don't recall this event as it was painful because one of the natural reactions is to freeze. And then you're just like, dead there, whatever is happening. You don't even know that's happening. But mentally, that is not frozen. And that is, working in the back end. And that's when you have this interview and then you have this history taking that could be actually the source, unconscious again.
Right. Right. Like you were saying that the pain memory.
The pain memory, but it's different
subconscious.
memory.
Yeah.
Well, in my work, like we talk about, the body remembering.
Yes.
Even if your brain isn't fully like, engaged in the moment because you need to like survive the situation. And so sometimes we talk about freeze, we're still kind of engaged in our brain, though, right? But we also have collapse response when you're not really like, maybe you're outside of your body, and so you're not fully present inside of your body. And so like you don't really know, but your body still knows.
Yes, exactly.
Your body is still experiencing it. So
that
sometimes like you need to unpack some of that as well as some of the medical stuff that might also be going on. And so I've definitely worked with you all in collaboration when, folks that we work with have experienced these kind of pain during sex.
And other reasons could be like, again, not associated with sexual trauma, but trauma. They felt that they had a straddle injury, as a child, and that was very painful. Yeah. And for weeks, this person could not, touch, pee, do anything, So again, that pain memory is there, and then anything that it will be similar to, oh my God, like something is coming at me, no thank you.
Well, I think it's important that we like make sure we're expanding the definition of trauma. I work specifically with people who experience sexual assault, but I think you're absolutely right. Like I think one of the things I was always taught as a kid that like, oh, like if some person with a penis tries to attack you, you're gonna like kick them, between the legs, right? Like that can be trauma.
Of course.
Right? Like you've had, maybe, I don't know what they're doing, not that they deserve it. Never mind. We don't need to get into that, but just sort of saying that.
I think people that are not even attacking you, most people with the penises have at some point
experienced
trauma.
During sports,
Right. But just say like that could be trauma, and that could be where they're experiencing, pain, or there could be like some level of trauma, or whatever. So just sort of naming that like trauma doesn't just mean the sexual assault; it does mean some of these other things too. Like you could have like a really bad experience with a GYN provider, and that can like
exactly, absolutely,
And the other addition to a trauma, it could be somebody who's not familiar with their anatomy. Which a lot of people aren't, and they don't know where to place things. So, example, a tampon, and they're trying to insert a tampon in an area that is not appropriate, and then it's traumatizing. Is so now again is that vision, is that memory, and that is another trauma. So it's not just sexual assault trauma; it's any kind of trauma.
You're bringing up some trauma for me, man. I was
so sorry.
No. I'm saying I'm sort of joking, but when I was in like middle school, I was the first person to get my period, and so I was like the tampon expert. And so I had to like help people to figure out like how to insert a tampon. So like absolutely, I think that still happens.
I was going to say the opposite. That I feel like the only reason I could still use tampons is because I had a decent first experience. Literally, my mom just showed me the box, but didn't really tell. She was like, "There's instructions inside," which there are with pictures. But she was like, "Pads are really easy, so just use pads if you want. But if you're feeling adventurous, you can use the tampon and figure it out yourself." And so, like, I think that the only reason I still to this day is because I had a decent experience that first time. I was like, "Oh, okay, this isn't so bad." But if it had been really terrible, who knows? So,
exactly.
Definitely, it's still traumatic. I'm curious.
I'm going to just say one more thing about sort of the other thing, of course, that we always have to think about with folks that are having dyspareunia is what is the nature of their relationship. If they're in a relationship, how is that relationship, right? Not everyone's in a relationship; they just have sex sometimes, and then that's a different sort of thing to sort of think about in terms of how we're conducting things. But if they're in a relationship, how is that relationship? Because that too, if it's a relationship where there's room for being able to say no and let's try something else and I need to work on this with the doctor. If that's great. If it's a relationship where it can't happen for whatever reason, then that also begins to obviously influence things, and that's also I think an important thing for us to explore. We don't always have the answers for those sort of scenarios, but to find out how to bring the right people to that solution.
I think that's a good point.
Really sort of speaking to power and control and dynamics within a relationship, and how that can add a lot of pressure into a relationship, and if there's pain in other parts of the relationship, then it can also, bleed over into, our sexual lives as well. But can you share with us a little bit about like what some of the like medical treatments are for some of these things that we've talked about? I know that I've, referred some, clients for physical therapy, or not me specifically, but talked to them about like physical therapy for vaginismus. But I'm wondering like what are some of the other things that like might be done for someone who's experiencing some of these things?
So if there is, again, depending where is the pain and what is the contribution to that pain. So if it is something that is dyspareunia, so penetrative pain, and it is superficial, so there are like exercises and, things that you can do to try to come to terms with this, approach, and then for you to be comfortable. And that could be as easy as to start with like a tampon insertion or dilators or something to that nature, because also there are conditions that can actually narrow or cause constriction in the vaginal opening. And then that per se is going to be painful, right? Mm-hmm. So to stretch that, to make that, happen. Also instructions about how to do penetrative sex when it's not hard, and then make the penis be soft and then hard inside. Mm-hmm. So that way it's softer the entry, and then it's not so like traumatic, Mm-hmm. So that's one of the techniques that you do. So there are a lot of things that mm-hmm. you can do. And if it's deep penetration pain, so again, you address if there is endometriosis, mm-hmm. there's an external mass, is she pregnant? Mm-hmm. What is going on, then you can actually instruct. And if there is a relationship, trust or mistrust, and if there is a problem in the relationship, how do we approach that? Because a lot of the time, that's really what the nature of the problem could be. Mm-hmm. And sex therapy mm-hmm. and exercises, that could be one of the approaches for that. If there is no anatomical, right, mm-hmm. Reason that we can fix or approach, and or if there is no infection that we can identify that is causing this mm-hmm. problem. So that's for the dyspareunia part. In terms of the pain itself, so if you control pain for one thing, then you might be able to unload everything else, to let everything else loose, So it can be all combined. So a multidisciplinary approach is necessary mm-hmm. To have, people that will treat the pain, people that will do physical therapy, people that will do the mental health aspect of it. So all of that is in conjunction, mm-hmm. okay? And the medical people who will then prescribe the medications or mm-hmm. do the mm-hmm. Operations or surgeries mm-hmm. that might be necessary, that kind of thing.
And just to clarify, the physical therapy we're talking about mm-hmm. is pelvic floor PT, which,
yes.
right,
yes.
which is what you were talking about with the vaginismus and the involuntary contractions mm-hmm. of the pelvic floor. I would love to hear your thoughts about, a lot of times when we talk about pelvic floor physical therapy, a lot of it is in relation to people with a cervix, mm-hmm. And I'm curious your thoughts about, if you think pelvic floor PT could be helpful also for somebody with a penis in dyspareunia, and what that kind of would look like.
Yeah, I mean, certainly it can be helpful. And, pelvic floor physical therapy is even used also for people who have problems with chronic constipation. And there's a number of different kinds of conditions that actually pelvic floor PT can be really helpful. But yes, someone who has, with a penis who has pelvic pain can sometimes benefit from that. There it's really, again, always about, well, what is the underlying diagnosis? Mm-hmm. It's, perhaps a little bit of a further stretch that strictly pelvic PT is mm-hmm. going to be the solution in those circumstances, mm-hmm. I have to say. But it can be a complement. Yeah. Mm-hmm. And certainly, there can be things that have to do on the in terms of vaginal health, in terms of being able to make adequate lubrication. Certainly someone who's perimenopausal or going through menopause often begin to have a little atrophy of the vagina and less natural lubrication. But that can happen also in younger women as well occasionally. So sometimes it's also just a question of hormonal approaches to help, improve the elasticity and the liquid, the liquid surface for the vagina. So there are a number of different approaches, really.
Postpartum patients, mm-hmm. lactation patients, mm-hmm. as well as people who are on hormonal contraception. Mm-hmm. Mm-hmm. Because again, it's the estrogen component that we are knocking down, and then that's the one that helps out to maintain that vaginal health.
Yeah. And similarly, people with cervix on testosterone, right? That can also dry out
medications. Absolutely. Mm-hmm. Yes. Mm-hmm.
Yeah. Well, I'm hearing that it's really helpful to know your body, which I think is something that mm-hmm. April and I talk a lot about, and being able to safely communicate, whether you're in a relationship or if it's a hookup or someone else, like what your body needs, right? Like if you're hooking up in the bathroom of a bar, then you don't have your lubrication. Like you may need a little bit more, but you're not you don't carry around, most of us, I don't know, I don't carry around lubrication. But maybe that's something that you need to do if that's like where your sexual project is. But if you're in a relationship versus at your home, like making sure that like your body, so that way you know what you need in order to hopefully prevent some of the pain and enjoy it a little bit more, even if you're not having pain. Like sometimes more, I think, April, you've said lubrication when it comes to sex.
But that's interesting that you said that, because of course not all of us will carry lubrication in our bags. Okay, that's an interesting point. But it will be interesting also because they will come and say, I have painful intercourse. So how many times, the last 2 times, what happened, all that stuff. But if you put the whole picture together, maybe that was the scenario, So it's not really dyspareunia, right?
Yeah.
Because it's not persistent, recurrent, over 6-month period. This is something that it's just happened.
Yeah. Well, and I use the bathroom example because like you're in a hurry. Like you don't have time to like do a little bit of the like the pre, like let's do a little bit
Lots
of
of foreplay.
Little foreplay,
around,
exactly. And so it's like we're just getting in there, getting the things done quickly, and therefore your body hasn't had time to self-lubricate.
Exactly.
Right? We might carry around a condom, but I'm sure not carrying around the lubrication.
Exactly.
Yeah.
And understanding all of that about the sexual response is so important. I think a lot of students use the sexpert, our sexual health counselor, to kind of understand more and more about how does all this work together. And I think that really does a lot. And even for someone who might need to be referred to a physical therapist or even a physiatrist for more advanced treatments for some dyspareunia, make sure that they really actually just understand their body and utilizing the resources, to really up that, I think, is really important.
Yeah.
And then as far as like the, so this is for vaginismus, dyspareunia, but for vulvodynia, which is the pain in the outside, so that's a little bit of a different because, there's no muscles there that are really causing the pain. So we talked about that it's more a nerve hypersensitivity or reaction due to inflammation or irritation, infection, lesions, a trauma or scar tissue, things like that, right? So for that, then depending on what it is, right? So we calm those nerves down with either topical medication or actually systemic medication. So we take some probably antidepressant medications might help. There are some neuroleptics there that are used, for this particular treatment. Has some side effects, of course, but depending on how much this is happening, I mean, there are people that cannot even sit. I had patients that cannot wear pants, underwear, so you titrate that pain down to be able to be more functional. And then from there you keep going and then you start around and, and then you make things better. And there are other treatments that are like trigger point injections where there's like a specific anesthetic that is used to inject the area to, again, tone down that, hypersensitivity. And ultimately, which actually is not an ultimate resource because it could be done primarily as a treatment, is surgery. Because when you prove out exactly the mapping of this pain, if it's specifically in the vestibule, which is the right opening of the vagina, you can excise that.
Like the nerves on the inside.
So it's a tissue, so right? So it's the hymeneal ring, right? So you excise part of that, and then by advancing some of the vaginal tissue a little bit further out, which is a tougher tissue, less sensitive, then it will reduce that pain. Of course, now you have the secondary side effect possibly of scar tissue stricture. It's a little complex. But it works. But it works, And again, there are different modalities, there are different things and approaches. Yeah. So not one for everybody. We just have to be each one. Yeah. It's your own.
Yeah. And I think the message we always try to impart is that it may take a while, but there will be solutions, and that it does take some patience and openness. And most people are like, great, bring it on, because of course, this is an important part of their lives. But yeah, I mean, we always want to find out, well, what's your goal? What's your hope for resolving this? And then work with that to then sort of craft the approach and monitor it and sort of look for improvement, and understanding of where they've gotten to and, what's making the difference.
Yeah.
So, but it can be a longish process depending on what's going on and how long it's already been there, et cetera.
It requires patience, compliance,
Yeah. But what I'm hearing is that like you have the ability to really sort of work individually and see the patient as who they are, what's important to them. And sort of one of the things that I think is so important in my work, but I think it's related to, medical professions as well, is to be able to be seen, heard, and understood. I've had some encounters recently with medical providers and I'm like, they're just not hearing me. Right. And so in this situation that is very personal, and all of our medical stuff is very personal, but like to really sort of feel like someone is listening to them and not just dismissing their pain, I think is so important and empowering in this process. Like we may not get it on the first try, but we're going to keep, working towards your goal, so long as that's what you want.
Exactly.
Right?
And I think that with my experience in all the practices and years that I have been and patients that I have seen, I would say to the students at the NYU that the Student Health Center have providers that are really dedicated to the student health. And we do take care of them. And we do actually, I think all of us, at least in GYN Health, truly listens to what they're saying.
Yeah.
And you can see it. I mean, when Gina sees somebody or my other colleagues, and I read their notes, you can see that they are listening to what the student is saying. These individuals have had this problem for a long time, and they feel that they were never heard,
Right.
And it's a shame, and it's sad because, why?
Yeah.
But it's practice of medicine, it's individuals. I mean, not everybody, is cut for the same, so they're lucky and use our services because definitely,
I think that's this conversation alone is good to normalize dyspareunia, right? Like I think that people might not even know that this is a thing, and they just might be like, oh, well, this is just what sex is about, especially if somebody has had sex from the first time that they ever started having like penetrative sex, or, I think that just knowing that it's okay to talk to somebody about it, even if they're like, oh, I don't know, is this dyspareunia? Is this just something else? Maybe do I need to change something else? But having the ability to come and talk to somebody and knowing like, there is a reason. Like, I'm not crazy for having this pain or for feeling like there should be something better or something different.
And if it's not dyspareunia, we can determine that.
Yes.
Yeah.
So it's not,
So a fair number of students have their sexual debut while they're at college, and some of them come to us after, the first try or two, and they're like, it was really painful. And they want to know, is my anatomy normal? And I'm like, let us work on that. That is their goal, is to know that their anatomy is normal and have that. And then sometimes that reassurance enough is good enough for them to say, okay, I'll go continue working on it. And of course, we talk about lube and communication and positions and, female-led sex in the setting of a female identifying patient. I mean, but sometimes that's enough. And I'm always pleased, if you will, that they just feel okay about coming in, early, right? Because, sometimes it can, really avert this kind of evolution to dyspareunia.
Yeah, you don't have to wait long. And you can see the GYN health providers, talk to this expert. I think that's a great recommendation to make an appointment with Alyssa and kind of talk about, is this normal? Is this not normal?
Right. Yeah. And some of the students come in and say they've talked about it with their family members, mother, siblings, somebody else, and that's always a great sign. Yeah. It's just like, that's great. You've got people in your
foresight.
Well, good. Hopefully they're not shaming them.
Yes. Right. No,
hopefully it's a positive experience.
Yes, it's true. It's true. It could be wrong.
But it could be one of those, like in the movies, like, oh my God, that hurt. Like, it's just crazy. Don't do that.
But the times when it's come up, it's usually been that it was that was their trustworthy person that they went to. So.
Are there other things that like put people at risk for potentially having issues or pain within sex? I'm thinking of, like, at some point I heard, and I don't know if this is true, that people who have eczema or psoriasis have like more sensitive skin in general, and so like maybe their genitals will also have like a little bit more sensitivity, and maybe they're more susceptible to having like a laceration. I'm wondering, if you all have any thoughts, or again, that's just like one example that I had heard, so I'm curious if you have any information or thoughts
Yeah,
around that?
I mean, there definitely can be eczema of the vulvar tissue or psoriasis of the vulvar tissue, and it definitely makes the skin more fragile. And so if that in and of itself is not being treated, yes, all of that you just basically described very nicely can happen.
But are there any others that that's just one that popped into my head, but if there's anything else.
there is a condition that is called lichen sclerosis, for example, and that causes this thinning of the labia at the outside, and then it becomes again, narrowing, very frail, very weak, and then breaks, tears. Okay, and there's also lichen planus. I mean, the lichen means a
sort of like a scar. Yeah,
it's scar, but it's lichenification is white. The tissue becomes white, so that's what lichenification is. It's whitening of the tissue.
Okay.
So it's like a descriptive term. I don't know what that means, but anyway. So those are lichen conditions: planus, sclerosis, and chronicus. Chronicus is becomes thicker, almost like an eczema type of skin harder. But even it's hard doesn't mean that it's not delicate. Okay. And then also because it's so hard, it doesn't lubricate as much, and then it can cause that pain as well. So it could
elasticity
be
is not
it's not as much.
Okay.
So all those skin conditions.
Okay.
Okay, these are dermatosis, which is one of the reasons why these pains happen.
Yeah.
Okay. Yeah. Thank you. That was helpful.
Yeah.
Anything else that you want to share with us around this, or anything else?
I think that I really appreciated that, you were talking about that multidisciplinary approach. And, it is, I think, one of the things that we are, have the luxury of working with, within the Student Health Center. And we've got great folks, and we've got this expert, we've got wellness. We can most of the time refer to, because we're here in New York City, we can refer to really good outside consultants. So that's sort of a special benefit that we enjoy to be able to provide for the students. So I think that that's important. And that, it often does require multidisciplinary. So I think that's also good for folks to understand when they're coming in for a problem, that it's us plus others, that will, bring the answers.
And their point of entry can be any of those.
Yeah,
exactly.
Yes, it's true.
Yeah. And also I want to say that, even though we seem to be on the same page, and we're all, describing these, amazing people that we work with, sometimes the chemistry between the patient and the provider doesn't out there. So you come in with a problem, and maybe it's your off day or my off day in terms of, how we're interacting, and then you don't feel that you have been heard or that your problem has been addressed properly. So don't be discouraged by that, because there are other providers that can actually provide that for you. Okay, so I want to say that because, personally, that happens every day. It doesn't manifest every day, but it does happen. And then, sometimes you are aware of it and you said, oh, I will never go back there. But try not to do that. Come back and try to see somebody else.
Yeah.
Because that problem is important, and we don't want you to go unattended.
Yeah.
I think that's really important. I like to tell people, you're not going to hurt my feelings if I'm not the right fit for you in order to meet your goals.
Yeah,
I want you to meet your goals. If it's me, great. If not, great. But I want to help get you there. That's my goal, even if it's not the right fit.
And every provider has a different personality, and I've seen 3 midwives, and they're all 3 different people, right? And they each have my best interest in mind, but each of them is one is a little more fluffy and warm and fuzzy, and one is a little more just straight to the point, and and none of them are bad providers. I think kind of what you're both saying, just who is the right fit in this moment for this thing. You're not going to hurt our feelings, but I agree that everybody at the Student Health Center cares about our students and wants the best for our students, and really is trying the best.
Because we read that. I mean, we read about the interactions, right? When you are leaving the room, you can tell. How you feel. What was the outcome there, and then you don't want that to be a bad experience. You want that to be taken care of.
I think that's helpful to know, and reminder that people have power within the context of their relationships within, doctors or nurses, people that have again, in our societies have, perceptions of power, but like really I think the goal is to make it a little bit more of a collaboration.
Yes.
And that I think is so important, no matter if you're at the student health center, but if you're you have off-campus providers, trying to make sure like you're feeling like you can speak up within the context of your relationships with the people that are there to help you, right? So like making sure that like you have the right.
Yeah,
exactly.
Yeah. And it's very, I mean, we have such a large international student population, and that dynamic of trying to do more collaborative kind of approaches may not be their medical culture at home. So sometimes it's a learning process too, that it can be it can exist. And we really want to support that.
Yeah. Well, thank you so much for being here.
Thank you for asking us.
If you have questions about the podcast or anything we talked about today, please feel free to reach out to us at goodsex.podcast@nyu.edu. This email address is monitored during business hours and may take 3 to 4 days for follow-up. We are definitely open to critical and thoughtful feedback, as we didn't cover everything in this episode and might have said something that was inaccurate or that had a negative impact on someone. If you have questions about your sexual health and are an NYU student, you can connect with our Student Health Center sex expert at sexpert@nyu.edu or schedule an appointment through the Student Health Center portal. Look at our show notes for additional information and resources, including organizations, articles, books, and videos.
If you have urgent mental health concerns, safety issues, or you are worried that someone might have caused harm to you, or that you might have caused harm to someone, then you can contact NYU's Confidential Wellness Exchange at 212-443-9999. Chat with them using their mobile app or email them at wellness.exchange@nyu.edu. For anyone, NYU or non-NYU listeners, you can call the National Sexual Assault Hotline at 1-800-656-4673, the National Domestic Violence Hotline at 1-800-799-7233, or the National Mental Health Hotline. Simply dial 988 from anywhere in the U.S.
Thanks for listening, and tune in to our next episode where we continue to talk about good sex at NYU. Subscribe to the podcast to hear all of our quickies and interviews with NYU community members. Thanks to our content contributors for this episode, Bernadette Kerr, Alyssa LaFosse, Dr. Dominic Baini-Amisa, Zoe Raguzios, and to our health promotion team, Anna Genova, Jenny Mellum, Parade Stone, and Arna Dixit, and to Gotham Studios and Karen Ortman.